the Cancer Kids Strength of Smiles Doctors Network, Maharashtra. And the topic for today's session is online lecture session on palliative care in pediatric oncology, what, when, why, and how.
Yeah, hi, good evening, one and all. So,
So,
yeah, please go ahead.
yes. So I would like to take this opportunity to introduce Dr. Juhi ma'am. She is the renowned consultant pediatric hemato-oncologist practicing at Fortis Medical Hospital, Mumbai. He is also currently practicing as a pediatric oncologist at TMH, Mumbai. Welcome you, ma'am, on board. She will be the honorable moderator for today. And now I also take this exciting opportunity to introduce our first speaker for today, Dr. Shamali Pujari, ma'am. Ma'am is MD in palliative medicine. She is currently the assistant professor of pediatric palliative care at Tata Memorial Hospital, and ma'am is also the proud recipient of ASCO IDEA PC Award at 2022. Welcome you, ma'am, on board. Next, we have our next speaker, Dr. Smriti Khanna, ma'am. Ma'am is MD in General Medicine, MRCP. She is the honorary consultant as a palliative and supportive care unit at BG Warrior Hospital for Children. Currently, ma'am is a renowned consultant of pain and palliative care at PD Hinduja Hospital, Mumbai. Welcome everyone on board, dear doctors. So, without further ado, Juhi ma'am, over to you.
Yeah, so thank you, Ritipana, so much. So, as we know that today's session will be we have experts on the panel and we'll be covering pediatric palliative medicine, that is the palliative aspect in pediatric oncology. And we have two speakers. So, first speaker will be Dr. Shamali Pujari, and she will be talking about understanding palliative care, as in what is palliative care, what is the when, how, why, and what is it when it comes to specifically pediatric palliative care? So over to you, Dr. Shamli.
Thank you so much for the kind introduction. Um, I understand that palliative care is a very new concept, and pediatric palliative care is even newer. So I hope I do justice to this talk. Can you see my screen?
Yes, we can screen your screen.
Yeah, okay. So to start with, I would like to take you through the journey of this young kid, excellent football player, well known in his school for playing football, smart, talented, has a lot of goal, very ambitious, wants to be a professional player, wants to earn a lot of money, has pain here and there in his leg, and most of the time the parents think it's because of lots of playing and because of its sports. This ignored for most of the time, then went to a doctor, MRI was done, turned out to be osteogenic sarcoma, had to get amputated, still tried to cope with it using prosthesis, trying to walk with support, using physiotherapy, occupational therapy, but seemingly very sad because he is now he's lost a limb. Moving on, after a few days, had cough, breathlessness, got a X-ray done, and this was the picture. Unfortunately, despite of adequate management, he's now developed lung metastasis. Got treated for that because parents wanted to do something, did not want to give up, eventually ended up in ICU alone because with had severe sepsis, neutropenic, very sad, alone, no one around. In this entire scenario, what we usually focus on is the diagnosis of the disease. But actually what really happens to the child, that was a healthy, playful child, had to undergo amputation, was unable to run, was unable to even walk without a prosthesis, without support. That is a major loss of role. It's even very traumatic for adults, let alone kid. Kid not being able to walk is too big. That's a loss of role. The pain, the constant pain. Amputation does not solve that issue. Most of these kids develop phantom limb pain. They are still worried. There is something called as total pain that we'll talk about later. When the child develops lung metastasis, the breathlessness, just the sense of being choked, sometimes feeling that they'll die because of that choking, that loss of breath, unable to breathe. It's very traumatic. And the suffering associated with it, we don't talk about that. Post amputation, the body image issue. Post chemotherapy, the cachexia causing body image issue, the loss of hair causing body image issue. We feel that children won't think about it, but that is absolutely wrong. We've had children who talk so much about body image issue, but we as adults, we as doctors do not talk about it. The fear of the diagnosis itself. Now we'll say that most of the children, we don't talk about diagnosis. That's not true. If you talk to the child, most of the child, especially in this adolescent age group, know their diagnosis. That fear is always there, that will I die of cancer, and how will my death be? Will I suffer? Will it be painful? How will my death be, or how will my future life be? And in pediatric, it's not just the child, it's the family. It's not just the parents also. It's the grandparents, it's the uncle, auntie who have been taking care of the child. It's the sibling, it's the cousin. And not just that, it's the friends, it's school teacher, it's neighbors. Everyone go through a lot of emotional changes throughout the course of illness, especially when it's something as dreaded as cancer. This study done shows that amount of suffering that the child has during end of life. If you see fatigue, pain, dyspnea, poor appetite, nausea, vomiting, constipation, diarrhea, and if you see the next bar diagram, hardly any of this suffering have been treated adequately and has actually given any relief to the child. All this brings us to the conclusion that when the child is suffering, the suffering has to be addressed and managed. And that is where palliative care comes into. So what exactly pediatric palliative care is it is prevention and identification and treating of the suffering in children with serious illness. So it's not limited to just cancer. It includes all those advanced illnesses that is causing suffering to the child or the family member. Who all can receive palliative care? I understand this is basically for cancer, but pediatric palliative care is not just limited to cancer. Cancer is just a part of it. So these are 4 points where you can actually refer the child to a palliative care physician. So if the child has any life-threatening illnesses where curative treatment is available but may fail sometimes, like in advanced malignancy or recurrent cancers, congenital heart diseases, when the disease is severe but non-progressive, but requires regular input from a palliative care physician, like severe cerebral palsy or sickle cell disease, where it's not progressive, but the child has a lot of suffering. Progressive conditions which require an intensive long-term inputs, where we know that the child is eventually going to develop symptoms over a period of time and is going to, and the life is limited, like cystic fibrosis, muscular dystrophy, motor neuron diseases, and conditions where treatment is only palliative, like we don't have any curative options, like trisomy 13, 18, any metabolic disorders. These are some of the places where adequate symptom control can actually play a big role in changing how the child and the family feels about everything. This is a very good picture depiction of what palliative care and what a teamwork can do, basically.
Ritu, is something wrong with the signal?
Hello? Hello?
We can hear
Yeah.
you now, Doctor.
We can hear you. Dr. Shamli, are you there?
Uh,
I
I'm
think we'll have
sorry.
to
I think I
the
got
screen.
disconnected. I'm not sure where did I stop at.
Yeah,
Were
yeah.
you able to hear this part?
No, we could not. No, we could not hear this part.
This one?
This one is done. The next one is where we lost.
Okay, okay. Sorry about that. I think there's some problem with my connection. Uh, I was talking about how we can use this metaphor to manage our patients. So it's all about teamwork, basically. So if you see in the first picture, the sea is very rough. It's only the oncologist who's sailing the boat. The rest of the team is somewhere around. We don't know who's doing what. And palliative care is like a lifeboat. During the end, when the ship is sinking, you'll try to just use it somehow and try to find out a way out. This is not a very good experience for the patient or the family. However, in the second picture, if you see, if you work as a team, where the oncologist, the palliative care physicians, and the child and the family work as a team to sail the boat, we will not really change the sea, but at least the perception that we are doing a good work uh, makes a big difference. And it's not just us, it's the multidisciplinary support team also. Our nurses, our psychologists, our social worker, our counselors, the occupational therapy, physiotherapy, interventional um, radiologists, all of us, if we work as a team, it's a much smoother ride for the child and the family. Where exactly and when can you refer to a palliative care team? So we know that any diagnosis, it's not a uh, smooth one. So there are ups and downs, there are a period of decline, and when the child gets a little better, but it's gradually declining only in general. So there are these time points where you can actually refer to palliative care. A being when there is actually acute decompensation and there is a diagnosis of some advanced illness, like diagnosis of a malignancy. Here we can actually help in pain and symptom management, because you'll see that pain is one of the most common cause because of which the cancer actually gets diagnosed. In solid malignancy, it's bleeding and it's fever and it's fatigue, mostly in hematological malignancy. So we can help in managing those symptoms, in coping with the new diagnosis. So helping the family live live through the breaking of the bad news, collaborating and communicating with the team members, because the family is usually lost at that stage on what to do. They are referred to get the biopsy, to get the blood work, for multiple analysis to multiple places, surgical team, medical team, radiation team, and sometimes they get lost through all this process. So we can help in collaborating that, and right from the beginning, manage the sibling as well as the family throughout, because siblings are the one who actually suffer a lot with the diagnosis of malignancy. The entire focus of the family is shift to the child who is now having the disease, and the siblings are usually neglected. So helping through that, identifying that and helping through that. And when the diagnosis is finally made and the child improves a bit, we can help them in living with the new normal. And this helping with the anticipatory grief of sometimes knowing that the child may not have a lot of time, the grief of losing a well child, absolutely normal child. Sometimes the family will just come to you that the child just fell down and now is diagnosed with cancer. So all that grief that the family has, the anger, guilt that the family has, we can help in dealing that. And again, continuing the coordination of care. Eventually, towards the end, when the child has sometimes unexpected decompensation, even during treatment, may have severe neutropenia causing sepsis, fungal pneumonia, all those decompensation where we don't know actually if the child is going to recover through that one event or not. We can still continue providing symptom management, assist with the decision making, whether to now continue further treatment or not. Help in setting the goal. Where do the child want to be cared for? At home, at hospital, in hospice? If the child wants to go back to the hometown, the family wants to go back to the whole hometown. If the child would want any further antibiotics or not, any further IV fluid or not. So all those goal settings we can help in, and continuing the comfort care. And eventually towards the end, when the child is probably actively dying or there is imminent death, we can help the family member cope, understand it and cope with it. Again, continue our symptom management, manage the siblings. And after the child dies, we continue our care by providing bereavement support to the family members. This is just a summary of where all can we play a role, right from the diagnosis to the crisis to relapse to end of life to bereavement. So these are some of our areas where we work. We work in ensuring that the dignity and respect of even the child is maintained by communicating truly and honestly what is exactly going on with the child, the diagnosis, the prognosis, but in a very gentle way, keeping the child and the family in the center when any decision is being made, understanding the place of care, their preferred place of care, preferred place of death. Symptom management, definitely a big role. Psychological support, spiritual support, just trying to help them adjust in their everyday life. It actually makes a big difference, and providing them um, a symptom-free or a distress-free death during end. Now, there's always this question of where can the child be cared for? Because most of the people would believe that, ghar bhej do. Send them home, shift them to a nursing home. Sometimes home is a good option, sometimes it's not, because we need to understand that some of them live just in one room house, where if the child is going to die there, probably with symptoms, because it's difficult for us to manage at home, we cannot go in there during any emergencies. So seeing that death might be traumatic for some family if they have a lot of kids in their home or elderly grandparents. So home may not be a preferred place for everyone, but yes, it's for most of the people. So definitely home-based care. We have our outpatient department. We can provide palliative care in inpatient by not being aggressive and just managing the symptoms. We are actually providing palliative care in emergency department also. Hospice facility, this is actually the ideal place for end of life if we don't have if home is not an option. Unfortunately, like in the Western countries, we don't have many hospices in India. We are lucky to have one in Mumbai. We are lucky to have it in Mumbai. So it's in Bandra, called as Shanti Avedna Southern. It's not specifically dedicated for pediatric. It's adult and pediatric both, but you can definitely refer patients there. Hospice is a facility where symptom management is provided without any aggressive investigation or interventions. There is like they use medicines to provide comfort, relief, psychological counseling, spiritual counseling, other supportive care, physiotherapy, occupational therapy. Everything is available over there, and fortunately it's not chargeable also, so it's a trust run thing, so it's free of cost for the family. So we can definitely refer the kids there. It's only for cancer patients as of now. There are other facilities, some facilities throughout India, which most of them only cater for cancer patients. So we have in Delhi, we have in Goa, we have in Bangalore, we have in Guwahati. And respite facilities, this is basically for the family members. If the child can be admitted in the respite care facility for few days, 5 to 7 days, and the nurses, doctors, and social workers in the respite care facility will be the primary caregiver for the child, when the family can actually take rest for some time. They can be with there, learn how to take care, um, uh, learn how to do the dressing, learn how to give the medicine, learn how to do self-care also, and then the family can be then discharged to home. So this can be between transferring the patient from hospital to home, you can actually keep the patient in respite care facility for some days to empower the family members. We know, palliative care is a new thing, so there are a lot of myths associated. These are some of the myths that are commonly associated, that the child has to be terminally ill to be referred to a palliative care physician. That's not true. We have something called as early palliative care, where right from the diagnosis of advanced malignancy, we can be a part of the team. Palliative care means giving up hope. It's not true. We will never interfere with the actual management of the child that is going on. So it's nothing about giving hope. It's about being truthful to the family and the child. Must have DNR, that's not true. Only for children with cancer, that's again not true. We've seen that there are many conditions that can receive palliative care. Must abandon all disease-directed treatment, definitely not true. Primary team abandonment should be abandoned, not true. In fact, we encourage that the primary team stays with the child right till the end, because they are the ones who the child and the family is the most attached to. So we definitely do not recommend or encourage not visiting the primary care team. Child will die soon if we not do anything. In fact, studies have shown that palliative care, it's an adult study, but it has shown that palliative care can actually improve life by 3 months. So not actually doing anything aggressive will improve life by 3 months. This has been proved in multiple studies in adults. So it's not true. All families want end of life at home. Again, as discussed, it's not true. Administering opioid will cause respiratory depression. Not true if done in a adequately trained setting with an appropriate dose titration. Does not cause respiratory depression. I have personally never seen respiratory depression in my career, and it does not hasten death. Something that is really important when we are talking about palliative care is recognizing imminent death, because this is the silver hour where most of the panic and most of the distress decisions are taken. So I'll not discuss in detail, because we know decreased swallowing, decreased food intake, decreased urine output, cold extremities, disorientation, weak pulse, change in respiratory pattern, noisy breathing that we call as death rattle. We no longer call it a death rattle. So noisy breathing, molting and cooling of skin, all these are signs of imminent death. And when we recognize it, it's easier for us to communicate. How exactly do we communicate that? So it has to be done in a very sensitive manner. We have to encourage the family to share their opinion on what they want to do. So most of our communication starts with how do you feel, what do you feel, and what are you seeing, basically. So never forget the siblings, because they are the most neglected part of the family when a child is diagnosed with any illness. Prepare the family for physical changes. So all those changes that we see, because they panic, urine nahi aa raha hai, they'll catheterize the patient. They'll, if the child is not feeding, they'll try to force feed the child. So just telling them these are the symptoms that you'll actually see during the end of life, and this will just predict that the child has very limited time. So just telling them in advance that this is going to happen really helps. Encouraging the family members to say goodbye, to say that they have done a good job and it's okay to let go, is sometimes what the family wants to hear. Provide proactive treatment for pain and symptoms. So end of life care is a time when you actually have to give medications, sometimes strong opioids, benzodiazepines, and not worry about the complications or side effects much, because that moment is going to stay with the family and the friends and the sibling forever. So if the child is distressed, that is really traumatic for the parents and the family. This is something that we really we do it for every patient, and it really helps explaining them what exactly is happening, all those signs. It takes some time, but it really helps in making them understand that the child is actually dying. and explaining that why it's happening. You feel that the family will not understand, but that's not true. Just that spending that 10 extra minute will actually help them understand everything and prepare for everything. And making and reassuring them that the child is not distressed by saying there is no mourning, there is no grunting, the face is relaxed, so don't worry, the child is not distressed or not in pain or not suffering.
Sorry to interrupt, Dr. Shamali, 2 minutes more.
Yeah, this last slide. And if the child is not comfortable, if the child is actually showing any of these symptoms like grimace, moaning, groaning, grunting, clenching of fist, something like that, then you actually have to change your care plan and increase the dose of medication or probably add some new medication. Discussing DNR, again, something that we all are really scared to do, especially in kids. So this is a line that we've been taught that we can actually use, and it really helps because it's a very simple way to talk about DNR with the family. We know as the cancer grows that the child is going to be sicker. We want to make sure that we do everything that will make her comfortable, like continue the symptom management, provide nursing care. But if at all her breathing were to slow down or stop, we are not going to put a tube or push her chest. That would not change anything. And what the child actually needs at present is that you be with the child and comfort her. So just this one line explaining DNR, it works. It works like miracle. So, and we need to understand that when it's adult patient, it's completely different. When it's the child, it's the child, it's the family, it's the sibling, and it's not limited to that. It's us also. Seeing a child suffer or die is not easy for us also. And especially if the child is distressed and really suffering, then that stays with us also. So we have to take care of ourselves also. Leaving you all with certain quotes that we have from our kids. So for the child, life is not about the cancer or the diagnosis. They have so many things that they keep worrying about. And we, as palliative care physicians, we try to listen to them. They feel happy when we do that. So, just simple things like, I want to eat pani puri, or I love eating pani puri. Just sharing that experience for them really helps. So what we do is we usually, when we discuss certain matters of difficult communication, this is something that we can use, that we are hoping for the best for your child, but we also need to plan if things don't go the way that we wanted it to. So this is one way where you can break the ice and start the communication. Thank you.
Thank you so much, Dr. Shamli. It was a very interesting talk, especially for me as an oncologist, where we are day in, day out just doing the oncology part. We never understand what goes behind and the thoughts of these children, especially. So it was really enlightening for me, as particularly as oncologist. Now we move ahead with the next talk. So as we know that pain is the most common symptomatology which we encounter in oncology. And we have with us Dr. Smriti. She will be covering the physiology of cancer pain, the management, and opioid stewardship. Over to you, Dr. Smriti.
Thank you, Dr. Juhi, for that lovely introduction. I'm going to go ahead and just start sharing my screen. Is it visible?
Yes.
Great. I think we are a little short of time, so I won't be covering too much about cancer physiology. It will just be a little bit about assessment, pain physiology rather. It will just be about assessment and management with focus on opioids, because I think that is that is a topic which everybody is quite interested to know about. So this shows you that many children, about 70 to 80% of children, have had pain in their last month of life, and unresolved pain. So that means that a lot of children have died in pain. And the cause of pain could be related to the treatment, it could be related to the cancer, or it could just be completely unrelated. Now, pain in children can be because of progressive disease. It can be invasive procedures or treatment that are causing it. There is a component of psychological distress which actually affects our perception of pain and how we manage it also. Just pharmacological management is not going to cover the psychological distress aspect, and hence you need a biopsychosocial model of care when you're dealing with any symptom, not just pain, because it is a biopsychosocial perception. And then we assess it using age and culturally appropriate tools. So it's a myth that children don't feel pain or children cannot express pain. Children can start reporting pain from 2 years of age, and there are various scales. Self-report is really the gold standard, but we can also use behavioral scales to assess pain. Now, I'm going to start from here. Now, pain in children less than 2 to 3 years of age, that is children who cannot speak or cannot express, and also non-verbal children, we usually use the FLAC-R, the revised FLAC scale, which is based on FLACC, which stands for faces, legs, activity, cry, and consolability. So this will be for really infants and toddlers. There is a specific pain scale for neonates, which is neonatal infant pain scale. So that is used for about 1 month to 1 year of age. And beyond that, we end up using FLAC-R. And so what it is that we have to look at each of these 5 aspects. And we, according to that, we give a number, and because this is 5 into 2, so it is 0 to 10. Most of our pain scales actually have a scale of 0 to 10, and a lot of the pain management is based on knowing what the number of the pain scale says. So that's why this becomes important. Then we come to the revised faces pain scale, which is for about children between 3 to 8 years or 4 to 8 years. Usually this is the kind of diagram which can be printed. So many of the nurses in the hospital actually have these pain scales sort of printed and laminated, and they can keep them in their pocket. And you show this diagram to the child and you say that this space tells you how much something can hurt. This one shows the least amount of pain. This one shows the maximum. So you tell me out of this, which one are you hurting? And children do actually they are able to report pain quite accurately with this. And then we come to the numerical rating scale. So once children attain numeracy, which is around 7, 8 years of age, they can use a numerical rating scale, which is basically a Likert scale for pain. And it's that simple, from 0 to 10, where 0 is no pain and 10 is the worst possible pain that you can imagine. Children above 8 years of age, it's quite easy to use this for them. There are some others. So the ones that we covered up until now, the FLAC and the revised faces and the numerical, are the standardized ones, but there are some which have found use regularly because we find them to be useful in all settings, whether socioeconomic, rural, urban. So sometimes it's difficult to classify pain as mild, moderate, and severe. So sometimes you just use finger span saying, is there less pain or is there more pain? And the reason why you just classify it as mild and severe is because even our pain ladder, which we will come to, is based on that. Or you can use a percentage of a coin. So 1/4, half, 3/4, or full. So jumping right into management, most of my slides on this are taken from these 2 guidelines they are the WHO guidelines, and a lot of palliative care, pain management comes from these guidelines. So the principles of pain management are by the mouth, because it is the most effective, the simplest, and the least painful route. By the clock, cancer pain is bound to come, and it should not be treated by SOS medications, because that's just going to increase the pain, and the child is going to be feeling pain at some point of time. Hence, we do give pain medication by the clock. By the ladder, which is the WHO pain ladder, which we will come to. And the fourth is individualizing and monitoring response to treatment. Now, in adults, the WHO analgesic ladder is 3-step. However, in children, it is 2 steps, wherein step 1 includes non-opioids and adjuvants. Adjuvants are part of every step, but basically step 1 is non-opioids, and step 2 doesn't come. So essentially, step 2 here is strong opioids, with or without non-opioids, with or without adjuvants. Non-opioids means paracetamol, NSAIDs, ibugesic, those kind of things, and strong opioids we will be coming to. Now, the 2 weak opioids, which are part of the WHO step ladder for adults, are codeine and tramadol. But in 2017, FDA released a warning for codeine and tramadol for children younger than 12 years. There is not very impressive data, but because this is a WHO guideline, we tend to follow it. So what it says is that codeine has a lot of inter-individual and inter-ethnic variability, and there are ultra-rapid metabolizers which will then cause sedation, and then there are poor metabolizers which will cause no analgesia. However, it's important to know that most of the studies have been done in Caucasians, and because there is considerable inter-ethnic variability, we don't have very robust data on Indian population. And the second is about tramadol. Now, what the WHO document says is that there is no data on the safety and efficacy of tramadol in children, but there are a few papers that I could find which shows evidence for use in short-term pain control, although that was for lactating mothers and the effects on the children. And there is also this study about tramadol versus morphine for adenotonsillectomy, which did not show a bad effect of using tramadol. In fact, I think there were lesser episodes of sleep apnea in children for this. So really, there isn't too much, there isn't too much evidence for not using tramadol out there, but there is still a WHO and an FDA one. So step 1 of the ladder, I'm not really going too much into dosages because I'm sure you know all of these, and non-opioid because they are non-opioids. So we have acetaminophen, ibuprofen. These are the 2 which are WHO certified, and then you have naproxen, ketorolac. These also can be used. Then we have step 2 in the ladder. Now, according to WHO, morphine is the drug of choice for severe pain in children because out of all the opioids, with the exception of the weak opioids, out of all the strong opioids, morphine is actually the easier available. It's cheap, it's oral, and it's very effective. It has a short half-life, 4 to 6 hours, and titration becomes easy because of that. So because morphine has a short half-life, about 4 to 6 hours, and because as per the WHO guidelines, we must be using medications round the clock, we use morphine as 4 hourly with double dose at bedtime. It is possible to just give medications every 4 hourly. In some countries, actually, in some of the hospices, they would wake up children in the middle of the night to take their morphine dose, but we prefer to just give a double dose at bedtime. Now, dose titration is if there is inadequate pain relief in 24 to 48 hours, you increase the dose by 50%. Each dose, so if a child is on 10 mg 4 hourly, that is also the PRN or the SOS dose. Morphine does not have a ceiling effect for analgesia, and in patients with pain, respiratory depression is very hard to find after giving opioids. And one thing that we always kind of miss is giving clear instructions to parents about the use of rescue dose. What has been found in cancer pain, one of the points about its physiology is that it's quite unpredictable, and breakthrough pain can happen at any point of time in the day. There is no set time for it, and therefore PRN or rescue doses become important. So formulations of morphine that are available are tablet, immediate as well as sustained release from 10 to 60 milligrams, and injectable morphine is also available. This is just a slide that shows what is the starting dose for morphine naive children. So we start with usually 0.2 to 0.4 milligrams per kg. That is especially for oral. For IV, it will be 100 micrograms per kg, and this will be the 4-hourly dose. There is an aspect of parenteral nutrition or parenteral medications called subcut medications, which is given a lot in palliative care, especially in patients who are at end of life, and we are finding it difficult to get IVs for them. And so subcut is basically a method of ensuring that the child doesn't get repeated pricks if oral medication if oral route is not a possibility. And so we can give around the clock bolus doses of morphine as subcutaneous. We can also give morphine as an infusion subcutaneous. We usually use either a scalp vein or a regular cannula, but just insert the cannula subcutaneously. So the other formulation or the other strong opioid that is available is fentanyl transdermal patch. It's effective, safe, and well tolerated. The only problem with transdermal patch is that it cannot be used upfront for pain management because you are not sure it's not going to be easy to titrate. And so the idea is that sometimes if a child is on IV fentanyl, you can switch to fentanyl transdermal, or on oral morphine and unable to continue oral morphine for various issues, swallowing disturbances, nausea, vomiting, compliance, you can switch to fentanyl transdermal patch. There are various apps available on the internet of how to convert one opioid dosage to another. So dosage is less than 15 kilos is 12, and 15 to 30 kilos is 25 microgram. You also get the patch in 50 microgram. IV fentanyl can also be used in pediatrics. We use it for patient-controlled analgesia, patients who need renal insufficiency and who have renal insufficiency and who need a continuous infusion, and for patients in which palliative sedation is being used. Dr. Juhi, we have about 15 minutes, and I know that there is a case. How fast do you want me to go? I think I have about maybe 7 to 10 slides left.
Yeah, you can, maybe 5 minutes would be okay.
Okay.
Yeah.
So the other strong opioid that is available is methadone. It's not very easily available. In fact, there is only one sort of supplier of methadone in the city, and Tata has its own supply. So Tata has a supply of tablets, whereas most of the other supply throughout the city is syrup based. But there is some evidence of methadone in children. In fact, some of the uses of methadone will be opioid rotation. Methadone has a lot of neuropathic effect because it acts on multiple other receptors also. And so if you want to do opioid rotation, if there is a lot of neuropathic aspect to the pain, and if there is side effects from other opioids, then methadone can be used. Methadone is also safe to use in renal failure. This is actually data of a small cohort of patients. I think they had 9 patients, and this is an Indian study. There is a Hyderabad group practicing pediatric palliative care, and they have used methadone in pediatric cancer pain and published results. But however, there is a lot of problems surrounding its use. Adequate training is needed. Pre-treatment, we prefer to do ECG, electrolytes, and magnesium primarily because there is a risk of QT prolongation and torsade points. But as was demonstrated in the study that I showed previously, all these cardiac side effects are less if you use a low dose methadone. So less than 30 mg per day, if you use, uh, uh, it is not associated with too many side effects. Now, the conversion rate of methadone is based on the sort of the total daily dose of morphine equivalent that the patient is getting. And the conversion rate varies depending on the amount of morphine that the child is getting in a day. So conversion becomes a little complicated, and that's why you need adequate training for it. Buprenorphine is the newer opioid. It's actually a partial opioid receptor agonist. But there is some evidence also now for use in children. It has a good analgesic potency. It's 30 times that of morphine. It has a longer half-life. It's still not licensed for pediatric use, but there are a few papers that talk about use of buprenorphine. It's important to know that this is the partial agonist. There is a ceiling effect for the non-analgesic effects, but there is no ceiling effect for the analgesia from buprenorphine. So this is a study which shows the patches that are available. We have only transdermal buprenorphine available, and the patches that are available are 7-day patches, and we have actually smaller patches, smaller doses than what I mentioned here. We get 5, 10, and 15 availability, but this one shows 3-day buprenorphine patch efficacy with 3-day buprenorphine patch of 35, 52, and 70 micrograms per hour. So it is efficacious, well tolerated in children, although it can be used as OPD treatment for cancer pain, although the time taken to kind of pain relief is about 3 to 4 days. That's what they had noticed in this study. So coming to side effects of opioids, constipation is actually surprisingly the most common side effect, and it's the side effect to which tolerance does not develop. Most of the other side effects tolerance develops, and hence laxative is a must when you prescribe an opioid. Nausea and vomiting sometimes happen in the first 3 to 7 days, so we sometimes prescribe dopamine, Domstal or Perinom along with it. Initial drowsiness, to which there is tolerance, and the patient will stop being drowsy. Itching and urinary retention is also a side effect. And then there are some toxic side effects which will either require opioid switching or completely stopping opioids, which is undue drowsiness, myoclonus, delirium, and respiratory depression. So these will require either dose reduction or you may have to do opioid switching. Just a quick point on opioid stewardship. There is an opioid. There is actually a picture I wanted to show, which was published in Lancet, about how the Western world or the global North has about 80% of utilization of opioids, and the rest of the global South or the LMICs actually just utilize about 10 to 20% of opioids prescribed in the world. So while there's an opioid crisis at one place, there is a scarcity in the other. And so opioid stewardship does become very important. There is one is that it should be prescribed by trained providers. It should be monitored well. There has to be a clear plan for continuation, tapering, or discontinuation of opioids. Most of the discussion that I have had today is acute cancer-related pain, but there is a rationale for using opioids in chronic pain, and that becomes a whole other kind of topic altogether. And there is a lot of attention to procurement storage. We have the NDPS Act in India, which helps us with that. This is a slide on adjuvant medications. There is a lot in cancer-related pain. I think I'm going to skip through because that way we can at least have our case. And then we come to non-pharmacologic therapy, which includes a lot of things: journaling, hypnosis, biofeedback. Play therapy is very important for children. This is just recommendation for their use. I think that we're a little short of time, so I'm sorry to rush through the presentation.
Thank you, Dr. Smriti. Still, you covered many important aspects, and I'm sure we will be more confident, when it comes to managing pain. And thanks for sharing your ideas. So with this, I think we'll move on to our case discussion, and if any questions, we'll take at the end. Is my screen visible?
Yes, ma'am.
Yeah. So, a short history, we'll be discussing one case, and I'm sure we'll cover many aspects and probably summarize what the previous two speakers have highlighted in the talk. So, this was a 17-year-old boy. He's a firstborn and he's the only child. Presented with complaints of swelling in the neck, which was increasing gradually over 6 months, hoarseness of voice, which was noted since 2 months, and noisy breathing and snoring at night, which had presented since few weeks. On examination, the vitals were stable. His weight was 51 kilos, oral cavity was normal, and he had bulky cervical lymphadenopathy bilaterally, and other systems were normal. So biopsy was done for the cervical node and it revealed a diagnosis of alveolar rhabdomyosarcoma, which is a soft tissue sarcoma known in this age group. And the PET-CT showed that the primary was in the supraglottis and oropharynx and it was causing occlusion of the lumen. And there were bilateral avid cervical nodes, supraclavicular node, and lytic lesions in the vertebra, sternum, pelvis, and right femur, suggesting bone marrow involvement. MRI also confirmed that, although the bilateral bone marrow aspiration and biopsy was negative. So, as you can see in the CT, that the primary is almost occluding the subglottic area and the oropharynx, and there were bulky cervical lymphnopathy. At this point, but the child was still stable and he had not developed any symptoms. So it was stage 4 ARMS, which was metastatic, and the stratification was high risk disease. Family was counseled about the disease, that it's an aggressive soft tissue sarcoma, which is metastatic. And molecular studies were further sent for prognostication and counseling the parents. And by breaking the news, the parents, he was the only child and they were young parents. They wanted to go ahead with treatment with curative intent. So my question to Dr. Shamali is how do we counsel the parents and the adolescent patient at this point, and at what point do we introduce palliative care?
So we usually start the counseling by giving a warning shot. I think just telling them that what we are going to talk about is you probably will not be expecting to hear this, or what I'm going to say unfortunately is we have a bad news here, or the reports are not quite what we expected. So something like that, we just give them a warning shot that whatever we are going to say is not great. And from then we start the counseling. So we have something called as spikes protocol for breaking bad news, where you can use it at every stage of counseling. So it's an acronym. As S stands for setting, P for perception. So setting has to be in a private area, with tables where the setting is so that the family and the child does not feel very intimidated by the doctor and they can open up. And we start by asking them questions about how it started happening and how it developed. And then we try to find out points where we can actually continue the conversation with. Something very important thing is to ask for permission to share news. Sometimes if the mother is alone, the mother might not want to hear the news at that point. The mother might want the father to come along with it. So just asking them that, are you okay? Should we share the news with you, or do you want someone with you? So just those small things that will make a big difference. Start from there. And talking to the patient or the child himself, this is a 17-year-old, so we'll have to ask the parent if it's okay for us to talk to the child, and we ensure them that we are not going to tell the child directly anything. At the same time, tell the parents that if the child knows or asks us some questions, we'll try to be as frank with the child as possible. So and if the child actually wants to know about the disease, it's better to create an environment where you can actually talk to the child about the disease, especially a 17-year-old young adult, adolescent. They usually know everything, so talking to them very frankly helps them also plan for things. So we'll do that if the child wants that. Coming to when to introduce palliative care, at this point, probably at the diagnosis of advanced malignancy itself, the family, it's the only child, the family will need support. The child is not very symptomatic at present, but does have some symptoms. So if you manage the pain and symptoms right from the start, the trauma of that pain and that symptom will not be there. So right from the beginning, if you have good symptom control, it's a good thing. So probably at this point, introducing a to a palliative care team is a good idea.
Yeah. And especially adolescents these days, they know everything. They have a
Yes,
mobile phone, they can Google. So it's better to involve them and, make them better prepared.
right.
Yeah. So this child was then planned, he was counseled and child was planned for neoadjuvant chemotherapy. While he was planned for it, he developed stridor. So he was started on oral steroids and he underwent a tracheostomy. He then was started in the same admission with IV chemotherapy. And he had a very good response to chemotherapy in the initial cycles. He also had a weight gain, and the weight was around 58 kilos. And gradually, we were able to remove the tracheostomy after appropriate care. So after 3 cycles, he developed blood-stained sputum and significant back pain. And the child said that the pain score was 5/10. He was started on paracetamol, escalated to oral tramadol and paracetamol. And at this point, the pain was manageable with this treatment. As we were treating him on an OPD basis, PET-CT was done to see the status of the disease, and it revealed increase in the primary mass, new bilateral cervical adenopathy, new lesions in axial and appendicular bone marrow, suggestive of disease progression. Uh, he did not have stridor, although at this moment. And molecular studies revealed that he had a molecular diagnosis of PAX3 FHR, which prognosticates that this is a very poor prognosis. And the prognosis, the survival is around 10 to 15% in these children. And intent of treatment was then decided in the MTD to be palliative. So to my question to Dr. Smriti would be that now that the child has disease progression, he does have significant pain and the primary is increased, also having marrow involvement. How do we control the symptoms of disease progression? And now that we have, anyways, we had an advanced malignancy, but now that we have the PET-CT and the molecular and the clinical, everything fitting into a disease progression, how do we counsel and break the news for this change of intent of treatment with the family and the child?
Let's take a question about counseling first.
Yeah.
Like Dr. Shamali spoke, any kind of breaking bad news, the same sort of pro forma we would follow. But at this point of time, it would also be important to determine the goals of care. And when we talk about goals of care, we talk about what the child and the family's values are. What are some things? What are some kind of critical functions that they would like to preserve right till the end? And critical functions could be something like walking. It could be something like being able to play with a sibling. It could be something like the child should just be allowed to just be able to speak till the end. And this is important because it helps us know what, if there are multiple symptoms to focus on, we may have to focus on one symptom more than the others in order to allow the maximum or the most sort of personalized quality of life that we can give for the child. How to have that discussion is actually a broad kind of a whole other discussion in itself. But knowing what the goals of the child and the family are is important over here. And sometimes this requires specialized counseling to at least to be able to break the news to the adolescent. Siblings are also important here. If I know that this is a single child, but many a time siblings go through not knowing what's going on with their brother or sister, and it's important to involve them also so that they also feel that they were able to at least take part in their siblings' journey. When it comes to controlling the symptoms of disease progression, I think that we are looking at two different kinds of pain here. There is bone pain and there is sort of somatic pain, that's coming out from the mass. Opioids are a very good, effective pain control for somatic pain, but not very effective for bone pain. And so we are going to have to tackle this at two different levels. So opioids will be good for disease progression. Other will be good for the somatic pain. Bone pains, we have to look at NSAIDs, we have to look at steroids, we have to look at if radiation can help control the symptoms. So these are the kind of three things that we will be looking at for bone pain. And also, I think at this point of time, discussing what symptoms can happen in the future is important with the family.
Yeah. So for the same we had discussed with the family and the entire oncology team. So for the primary tumor, he received local radiotherapy, which was around 50 gray, which was a proper definitive radiotherapy dose, and which controlled all his primary symptoms because of the primary mass. And for the bone pain, he received palliative radiotherapy, as Dr. Smriti mentioned, and he was opioid was, it was on oral tramadol and paracetamol every 8 hours. And since this was the only child and parents were very anxious, we discussed to start on oral metronomic chemotherapy for symptom control and to try to, at least alter the progression if possible. So on the second week of the oral metronomic chemotherapy, he developed severe pain, lower back pain, pain in the left leg, and the pain score was 10/10. He was admitted and started on oral morphine, 5 mg intermediate release, 4 hourly with a laxative. And he also required 2 rescue doses, each of 5 mg in between. And since he was having radiating pain, even gabapentin and tryptomar was added. Pain was somehow better on this combination when the child developed acute urinary retention requiring catheterization. So, Dr. Shamali, we've already discussed it that yes, can morphine cause urinary retention? How do we manage the side effects in this child? And more importantly, my question is that what is total pain, and could there be a component of psychological pain also in this patient since he's an adolescent?
So yes, morphine can cause urinary retention. It's not very uncommon because it acts on the mu-opioid receptors, and the mu-opioid receptors are also present in the bladder. So any opioid can actually cause urinary retention. And this child was also on amitriptyline, which again can cause urinary retention. So something but we also need to understand that most of the time then we tend to associate that retention only with the opioid, only with the amitriptyline. So we need to keep a broad open mind and look out for other causes of retention also. So that I think Smriti ma'am has talked about the side effects, how to manage the side effects, so I'll not go in that. Total pain, yes, total pain is a very real concept. We have to have a very good assessment to actually label it as total pain, because here clearly there is a reason for the child to have pain, and probably the dose is also not appropriate to the age and weight of the child. Even if you convert tramadol to morphine, it is still giving a lower dose of morphine. So total pain in adolescents, we've seen a lot because they have a lot of issues. Sometimes the issues that we do not really explore, like friends, girlfriends, social media, body image issues, so basically hair.
Just a second. Ritu, can you mute everyone else?
Yes, ma'am.
So body image issues, sexual issues, something that we do not really explore many of the times. And when we talk to the child, many of these issues have come up, and just speaking to them have actually reduced the pain in the children. But exploring is very important. We cannot label it as total pain without actually exploring all the components. So physical, psychological, social, spiritual, all this component we need to explore whenever we talk about pain, which is not, which is something that will not correlate with the actual disease burden, or we've given the proper dose of opioid, adjuvants, non-opioids, and yet it's not being managed. So.
All right. So yeah, when we did a clinical exam, it revealed that there was lower limb hypotonia and there was paraparesis with urinary retention. So we assumed that there is some infiltration into spinal cord, although we did not do any imaging because we were clear with the intent of treatment. He had unbearable pain requiring admissions. So we started him on IV morphine infusion, which was started around 20 mics per kg per hour. And that was 1 mg per hour. And his pain was well controlled with the IV morphine, and he required few boluses in between. Since his marrow was involved, he had low thrombocytopenia. PCA was not unavailable at center. We wanted to shift the child to oral formulation so that we can send him home, but that failed. He was more comfortable on with the IV. Parents were also feeling better when the child was on IV morphine. We counseled them about the terminal condition of the child and explored option of home-based palliative care, but we were unable to. Parents were not comfortable. They were not confident. They wanted him to be in the ICU with on IV morphine. And unfortunately, the child expired in the ICU on morphine IV after 10 days. So this is a practical problem we face actually. And so I wanted to ask Dr. Smriti that how do you manage severe pain in these patients? And we want to transition them, as we discussed earlier, to home, but practically sometimes we are not able to do so. So what is better? How do we go about it? Your comments on that.
Could you just go back to the previous slide?
Sure, sure.
So yeah, sometimes I think there are a couple of problems here. One is that pain was unstable for this child. It just kept changing, it just kept increasing. And the type of pain, like it moved from somatic to bone to neuropathic. And so then this is really like a complex issue. And so he would have required admission at least to be able to for the initial management and kind of stabilization. And it's quite possible that oral morphine trial also would have failed. One thing that we could have done if we were considering moving him to home was having him on a subcutaneous morphine infusion from IV. A subcutaneous morphine infusion is easier to manage at home. There is no issue of kind of finding out IV medications. There are some qualified nurses, some qualified palliative care nurses even doing home care, who know how to handle the infusion and what are the sort of the side effects that you have to look at. There will be a lot of other side effects, constipation, those kind of things, which will also have to be seen. The other thing that can be done in a child like this, if we have optimized neuropathic bone pains, we have looked at it from all angles, is going to be palliative sedation. Now, palliative sedation is a concept that needs a lot of kind of understanding and explaining, both on the side of the physician as well as on the side of the family. So the premise is that not always we are able to do symptom control maximally, and so if distress because of symptom control increases to a large extent, then sedation, just in order to reduce the perception of the symptom, whether it is pain, whether it is breathlessness, whatever it is, that becomes the next option. And so usually we would give a mix of a benzodiazepine with an opioid, fentanyl with midazolam, or morphine with midazolam. Sometimes we need to add a prokinetic for this because this causes a lot of gastric stasis and something to manage constipation. Along with this, if the child is sedated, then there will be some amount of parenteral nutrition that will have to go, also via the subcutaneous route or via a RT. So enteral or parenteral nutrition, he may not be able to take orally. So these are some of the options that we have in a patient like this. It's not going to be easy to transition to home, especially if you have palliative sedation or even an IV or a subcutaneous morphine going on, this is actually an ideal case for a hospice. So what we could do is give hospice-like care, but in the hospital. Shift him out of ICU, shift him to a single room where the family, whoever wants to stay with the child, is able to stay with the child. We are able to do our monitoring, and we are able to cut down on other inessential medications to the extent that we are only looking at end of life care and symptom management.
All right. So unfortunately, because of the hospital rules and there are certain things. I mean, we could not deliver IV morphine in a ward setting,
Yeah.
and there were a lot of things which, because we are the administration and the nursing and everything is not that comfortable with. So sometimes practically we do face all these issues when we know that these things actually could have been done in a better way or in a better setup. We are actually not able to deliver it in few cases. So I wanted to discuss this case especially. Yeah. So thank you so much. Uh, I would just see if there are any questions. So there is a question asking cognitive behavior therapy for patients and families. So this would be, I think, a part of psychological counseling, I assume.
So CBT usually has very specific indications, anxiety specific to a particular kind of situation and things like that. If patients and families who are going through a difficult diagnosis, the most important thing would first, I would say, be general counseling. There will be a lot of questions that are unanswered. So looking at all of that, and then if there is anxiety towards a specific thing, or there is an element of depression also, which is not just adjustment disorder, then CBT might be a good option.
And one question, opioid causes vomiting and constipation. How do we deal with them? I think we have already discussed. Yeah.
Stool softeners are not very useful always, so stimulant laxatives are much better. And opioid-induced vomiting responds better to domperidone or perinom or metoclopramide rather than ondansetron or 5-HT4.
Yeah. Kindly share some insights on quality of life assessment in pediatric pal care and how is it different from adult pal care? Maybe Dr. Shamali, you want to take it?
So we have some questionnaires to assess quality of life in pediatrics. So there is something called as PedsQL. We need to understand that this quality of life questionnaires are usually long questionnaires, like 20, 30 items, and it's very difficult for us to make the child, answer those questions, and it has to be age specific. So the subsets of the questionnaires are different for different age group in PedsQL. So most of the questions are school related, homework related, or general knowledge related. And the other thing is it's validity and it's not valid in, it's not translated in Hindi and Marathi and the local language, so it's in English. So that again becomes a barrier to administer quality of life questionnaire. Whereas in adults, it's different. We have many disease specific questionnaires that we can do. Again, they are also very long, and the patients usually get tired filling those questionnaires. But we have options there. We have short forms of those long questionnaires. In pediatric, we don't have many questionnaires. So that would be one difference.
Okay.
Contraindication for opioids. So there is actually no contraindication for opioid as such in palliative care. We have different kind of opioids if the patient has renal dysfunction or liver dysfunction. We can use fentanyl, methadone, buprenorphine safely in those patients. If the patient is not able to swallow or eat tablets, we can give transdermal patches or sublingual tablets of buprenorphine is available. So there is no contraindication as such for opioids. We just have
All
to
right.
adjust the doses.
Yeah. And as you mentioned, there is no cutoff or ceiling dose also. Then,
No,
right?
there is no maximum dose for morphine
All
specific.
right. So I don't see any more questions. So I think we'll close the session. Thank you so much, Dr. Shamali and Dr. Smriti, for a comprehensive talk. I mean, there were many aspects which were covered, which generally we don't get to.
Yeah,
Yeah.
Dr. Monica, can I speak?
Yeah, please speak.
One, yeah, I'm
Yeah,
Dr. Amit.
Dr. Basant.
Yeah,
I think we'll take Dr. Basant and then Dr. Amit.
no
Yeah,
issues.
Amit,
Yeah,
go ahead, Amit.
Yeah, any of
yeah.
you.
So the thing is, I just wanted to have ask one question: is there any regulation on the number of doses of morphine that can prescribe in a single OPD setting, or if a patient comes from a far-fetched place, then he may not be able to get morphine for maybe if he needs morphine there. So can I prescribe morphine for 1 month or 2 months? Is there any regulation of number of days that I can prescribe morphine? Anyone, Dr. Smriti or Dr. Shamali? Hello.
Shamali, would you like to take that? I think Tata has a much sort of more
Yeah, so it
regulation.
actually is kind of a hospital policy that we will not, and a departmental policy. I would not say hospital policy. It's a departmental policy that we'll not give more than 1 month prescription because we want to monitor those patients. Eventually, this child, these even adult patients, their functions are going to decline. So there will be more chances of side effects. So we want to monitor that. So that's why that 1 month period is there. Um, there are limits to carry opioids during transportation, like flight and train. Probably not because no one checks. But for flight, yes, there are certain amount that you can take, and there are numbers for how much you can store in your OPD or in your clinic, per se. So not for the patient.
Okay.
It's more on
Thank you.
what would be your hospital rule and department rule.
In my hospital, the problem is it's not every.
Sorry, sir. I think you got disconnected.
Yeah. Mr. Basant Kumar, you would like to go ahead?
Big
Yeah,
hospitals.
We lost you, Amit.
Yeah, the thing is that in my hospital, I morphine just in IP pharmacy, not in OP pharmacy. So if the child needs a morphine prescription, I have to admit the child, prescribe, get the morphine from IP pharmacy, then discharge. So it's not available in even in big hospitals in OPDs, OP pharmacies. So that's why I was how to give prescribe morphine in these cases.
I think
So
that is what we are working on in advocating hospitals to prescribe opioids and let the patients have opioid in home setting also.
okay, thank you.
Thank you.
yeah.
Yeah,
Can
no
I
question.
speak?
Yeah, please.
Yes, sir.
Yeah, Dr. Shamali and Dr. Smriti, very nice webinar. Yeah, really. You people are amazing. Actually, my query is that definitely we can get morphine easily at our center. But in long-term morphine use, what is the or two things is that one is the respiratory depression, distress, depression. You can say respiratory depression, and other is the tolerance about that drug. How we can monitor the child? Is it is any guideline or any policy to monitor for that? You got my question or not?
Yeah. So with regards to respiratory depression because of morphine, most of the morphine that we prescribe in an OPD basis and even in IPD is oral. There is little to no respiratory depression that happens with oral morphine, very minimal with IV morphine also. The rationale is this, that in patients who have pain, if the pain is not adequately controlled, no matter how higher up the dose goes, that actually inhibits the depression of the respiratory center. So then respiratory depression is a very sort of minimally encountered phenomenon. That being said, we also need to have opioid antagonists available on hand, and we need to have it as part of narcotics policy. It should be part of our, say, emergency drug trolleys and all of that. There are specific scales for how to assess for opioid. What do you say? Pinpoint pupils or respiratory rate coming down, or those kind of things. So we need to be on the lookout for that also. Your second question was about, sorry?
Sorry, tolerance of the dose. Hello.
Yeah. So opioid tolerance is usually managed by opioid switching or opioid rotation. So if one opioid, there is some amount of cross tolerance, but it is not complete. And this is where opioids like methadone and all actually come in helpful.
Thank you, Dr. Smriti.
All right. So I think we'll conclude our session today. I mean, it was a really good discussion and a lot of questions, and we answered. A lot of queries were also solved. So I think, all in all, it was a wonderful session. So thank you so much, Dr. Shamali and Dr. Smriti, to be our experts today. And with this, I would like to close the session for today. Thank you.
Thank you, Juhi ma'am.
Thank you very much.
Thank you.
This opportunity.
Thank you.
Thank you, everyone.
Thank you. Thank you. Thank you.
I hope you had a seamless experience. And thank you once again for extending us the opportunity to host this session. So looking forward to host you again very soon. Thank you. So with all your permission, we are signing off for today. Till then, stay safe and healthy, and good night to all.